So good afternoon, everyone. We are going to have today's session that is on like how to form or how to draft the blueprint for assessment. And we have, I think this is for the first time we are having a workshop on a topic which is related to the medical education. And since we thought that this topic is somehow related to the calculation, because if you think about the other medical education topic like question paper designing and teaching learning methods, micro teaching, etc., that's a relatively conceptual where there is no need of much of the calculation part. But in case of a blueprint, uh, we developed blueprint for our department and we faced the issue of a lot of ambiguity and again how to calculate. So because of that we just plan to do a workshop on this topic, and I hope you will get some insight out of it and few of you will be motivated to have your own blueprint in the department. So with this preset, we are going to have this session. So this session we'll have one breakout room activity towards the end, because you people have participated in the activities and we have the data sheet of all of you who have responded, and then we will share that sheet to you people and you will do the activity in the breakout room. So I'll start this workshop with this qualitative study, which was done in Pakistan, and it was a qualitative study inquiry of the university student experience on exam stress and its effect on their academic performance. So all of us have passed through the stage of being a student, and now also when many of us are doing probably fellowship or some advanced courses, then also if you have to appear in the exam, the stress is very much similar to what we felt when we were undergraduate or postgraduate students. So, using the theme of this qualitative study, we have recreated this in the form of a story. And the story is that a story of a Anam, who is a girl, and how she's describing the night before the final exam. So, she says that it's the 2:45 a.m. in the morning, and there's a lot to study. Again, the things which is going in her mind, in her psychological domain is, what if I fail? And the words are roaming in her mind because teacher used to say that no, read everything because everything is important. When she asked from seniors, seniors also said to her, you never know which topic will be asked and it is quite unpredictable. So she's in a kind of a confused state, what to leave, what all to study. And then the words of her mother is also roaming in her mind, like you have to do well in the exam. And then the peer group, like one of the friend, she's saying, like, who always seem to be very confident that I have studied everything. And what about you? Have you finished your topic or not? So like she's turning the pages, but no, nothing is going in her head. And like words seems to be very blur and she's totally confused at the mid of the night. And then just before sleeping, she is saying to herself, I have studied, but I don't know if I have studied the right thing or not. Because she has studied many things, but she's confused, like whether I'll pass or not. And whatever she has studied, whether it will come to in the exam or not for the assessment. So many of us can correlate this narration, because if you can recall ourselves when we were UG, many of us have faced the similar situation. So, yes, the question is again to you. Have you ever felt that while doing the assessment, that certain important topics which were important for the exam, but they were not adequately represented in the exam? Yes, please answer in the form of a yes or no. There can be no also because many times experiences are different for different people. So like Priya, Priyanka, Dr. Virendra, Dr. Sushri, Dr. Sheena, Anupriya, yes. So we all have felt this, that many times very important topics, they were not adequately represented in the exam. And many times you will see that students who are scoring high, but they fail in the real life clinical scenarios. I think many of us, you may be in touch of many of your friends who used to be topper, like university medical examination, but when actually it came to practice, they were not that much successful. And many students who were not very, good at theory, they were very good at skill. So you will see this, the pattern of our assessment is like that, that many times the students who are very studious and who are very theoretical, they top the examination, and the students who are very practically oriented, they don't get those many good marks, because our assessment pattern, mostly we assess the knowledge and not very frequently the skill part. So this what about you guys? Do you agree with this? Many students who are scoring high, but they fail when they face such, real life clinical scenarios or clinical acumen. Most of us are from the family, this community medicine background, but here also you will see that many community medicine people, they are very good at, at clinical, community clinical work. Here also in our PG students, we see that many students are very good at communication, talking to the patients, consoling, counseling them, and many students who are very good at writing the answer sheets. So the people who are very good at talking and very good at patient front, if they can't write well, they don't get good marks. So that's the problem of our assessment system. And we also have felt that many times the internal assessment and final exams, they are not always aligned with what we have taught to them and what we have emphasized. So yes, this question is to all of you. You have to, many of you who at least you have to write one challenge which you faced when you were planning assessment, because I think all of you are at every stage of this professional growth, and many of you are involved in, doing assessment. So like Priyanka is writing, many toppers are not able to clear their PG exam with good rank. Okay, yes, Priyanka. So what is your answer with this? Any challenge, if at all, you may have faced with your interns? Generally, we don't take, but with your UG students, any challenge which you faced in planning assessment? How do you plan assessment generally? Whenever the exam comes, like what we used to have, if uh, anybody is writing, then otherwise, okay. Like generally, what used to have at our place, whenever the exam used to come in just in a hurry, we used to set the question paper. And we don't see, like, if the question paper comes to us. So Priyanka is writing. Can you just put that chat? The upper one is got missed. Yes, so Priyanka is writing, our assessment tests only knowledge part and not skill. Okay, that is one problem. Ria is writing, challenge is making case-based scenario questions, LAQ, MCQ for community medicine exam. And Dr. Violet is writing to appropriately assess all topics. True. Rajat is writing, challenge is credibility issue in online MCQ. Okay. Haripriya, topic-wise marks distribution while planning assessment. Sushri is writing, we get some questions repeated in the form of a long and MCQ. Aradhana is writing, teaching does not match with assessment. Very true. And Glory is writing, all topics don't receive appropriate representation. Very right. And it all depends on the faculty. See, like if I teach epidemiology and communicable diseases. So if I am the question paper setter, I'll try to include all the questions, mostly the questions from the topic, because I have taught them. That's a bias. Again, what happens many times, if we are in a hurry and we don't have time to set the question paper, what do? We take the question paper of last 5 years, and those questions papers were also, we have drafted those question papers in hurry, and because and then we take questions randomly from the previous 5 year, one LAQ, 3 4 SAQ, few MCQs, or few MCQs from the last 10 years NEET PG exam. So nothing is like you can say planned. Everything is random, and it all depends on who is setting the question paper. So there's a lot of subjectivity in assessment, and we will see the basic rules of assessment. Then whenever we plan assessment, we introduce two terms, that is validity and reliability. We will learn about the validity and reliability. But again, we have seen that the assessment is I mean, the assessment, the kind of assessment which we take, that's quite subjective. And still, we are not in the process of making it more objective. And what is the one consequence which you have seen of an unstructured assessment? Yes? Any experience you can, like, can you share? Not even experience, few incidents or anything you want to say. Any consequence which you have seen of an unstructured assessment? Consequence means, like, I can say about myself, uh, many times, like, when the 2012 batch came initially at the AIMS Patna, that time also we were not having a very good idea about these blueprinting and all. So we set the question paper with the topic which was a very favorite of our HOD, and then the students, they did not read that topic very well, and the consequence was, like, many of them, they did not cross even the passing marks, but they were all good. So that was the one consequences, because that topic was very favorite to the HOD, or maybe the person who has just attended a workshop, or maybe you can say what you say general seminar or workshop or some course, and he drafts the question, basically taking the input, because whatever he has read recently, he has set the paper according to that. Many of our faculty also shared their experience that when they appeared for their PG exam, the question paper which they got, it was so difficult, and when they searched back, it was some, like, a review, not even a review article, some concept of some person who has presented that in an international workshop. So that's out of that's all random, it's nothing was planned. So again, Anupriya is writing, the evaluation gets biased. So when students, they are not sure about okay, so Dr. Aradhana is writing, in spite of knowing the answer, the student is not able to express it well. Very true. So when the students are not sure what will be assessed, how it will be assessed, and why it is being assessed, then the learning, whatever the learning they do, becomes reactive. Reactive means, like, they are just doing it blindly rather than intentional. They don't have any plan in their mind, and it becomes like a trial. They are undergoing some trial, and the whole process becomes so stressful that they don't enjoy. Just think about the word exam. Even if uh, now also, if we have to, students, if they learn this, or they listen this topic exam, they just become panicky. So this assessment is a kind of stress giver rather than making it as a good experience. So uh, the good, because since now we all are at a faculty level, so we can change the system of assessment. Those of you who are interested, we can give it a try, and then see, because now all of us, like, blame each other. We say that students are not reading, students say that teachers are not teaching. So rather than blaming each other, we should start something with a very transparent this thing, that's to have a assessment blueprint. And we will share towards the end that we should share this blueprint to our students, so they should also know what will be asked and how it will be asked. So the specific learning objective of this workshop is to understand the concept and purpose of blueprint in medical education, and we are assessing the we are doing the blueprinting for the assessment, because there's a blueprinting for several things, and this is the workshop of blueprinting for assessment. And then to recognize the components of assessment blueprint. Then the third objective is to appreciate the alignment of blueprint with curriculum. That means to how we can align the curriculum with the assessment blueprint. And then fourth is to learn with the real data set, which you people have responded, and we'll see towards the end how you can make a blueprint out of that. And the last is to use the interactive Excel tool to design a blueprint. So these are the 5 specific learning objectives of this workshop. So what is this test blueprint? So this test blueprint, it is also known as the test plan, table of specification, and test specification. And we have taken these references from many of the article and 2 textbook, and we'll share the references with all of you so that you can also go through them. So now what is a test blueprint? So basically a test blueprint is a content, is a drafted content where what all to be tested that we mention, how much weight each content should have that we write, what will be the assessment format, like will it be multiple choice question or short answer questions or essays, and what are the cognitive levels, like whether it is a, we will see the cognitive level. Many of you know already what is this cognitive level. So you can see this, and then whether you want to test the cognitive level at the level of recall, at the level of application, or at the level of analysis. Now, this is one example of a test blueprint, and you can see like this one here. This is again, this is a blueprint for summative assessment of theory in the community medicine. And here you can say this, see that this is the content. So this chapter's name are written like basic biostatistics, concept of health and disease. So this is the content. So we have learned what is a blueprint. A blueprint is a specification where we write the content. Then the next we have the weightage. So if you see the second column, it's the weightage. That means it says that the basic biostatistics weightage is 5.6%, concept of health and disease is 5.9, disaster is 6.8. If you see the epidemiology of communicable disease, it is 25.8. So it has got a content. We mention the relative weightage. We mention the type of assessment questions also, like whether it will be of MCQ, short answer question, or long answer question, or only MCQ or only LAQ, depending on your university or your institute's requirement. And it also has got a distribution, like what will be the distribution of MCQ, SAQ, and LAQ. So this is a rough, and then it has got a grid. You may or may not have this grid, which we are showing it here, where all the detailed breakup of this marking system is there. We will draft a blueprint like this at the end of this workshop. Towards the end, when we'll do the breakout room activity, we'll demonstrate how to populate these individual cells and how to do this. So again, like we have seen, a blueprint is a table of specification. It is a grid of content areas, domains, and tool of assessment. And it indicates mark carried by the each question. So in this, the previous example, you can see it is a grid of specification which has got content, which has got weightage, which has got the assessment pattern, type of assessment, means what assessment method we are using, whether we are using MCQ, SAQ, or LAQ, and it has got the relative weightage of the MCQ, SAQ, and LAQ. Now, if we have a, like all of us were sharing our experiences, if we have a assessment without a blueprint, what will be the problem? So if we have assessment without blueprint, we will choose the arbitrary topic. That means topic which are very less important, but we are giving the more weightage to them. So then we will be missing the learning objective, and there won't be any alignment between our learning and our assessment. There will be a overemphasis on recall. Like we were all discussing that Generally, the people who are very academically oriented only in terms of theory, who can cram things, who can memorize things for longer duration, and even the rote learning, what we say, we are basically promoting the rote learning. Because if there is a overemphasis on recall, then again that student, they will perform very poorly in the clinical acumen. And if we give inconsistent weightage to the topics, then again it will be the injustice to the students' effort. Because if they are studying something and it is not being assessed in the exam, then it is a injustice to them. And again, there will be lack of, if the assessment is without blueprint, then there is a lack of alignment. That means it is a confusion both for the teacher and for the students. But what if the assessment is with blueprint? So if the assessment is with blueprint, then the topic, whatever we will select, because you see that all the content and the marks distribution from that content is fixed, relatively fixed. Then the coverage of the topic will be very structured, and it will be very fair and valid assessment. And we'll see it increases the reliability and validity of assessment. How? That we'll see. Then all the domains will be balanced. We will see about the Bloom taxonomy and about the Miller's pyramid also, because in this knowledge domain also, if you see, there are various levels of knowledge. Like there is a only knowledge, and then there is a application, and then there is a analysis. So all those, there are different levels of knowledge. So if you form a blueprint, then of course you will have both the cognitive, psychomotor, and affective domain. All the three domains will be there. And the system will be very transparent. All the students know what they have to study. There is no confusion at their end. And all the teachers, they know what to assess and how to set the question paper. So it is good for both teacher and student, and it aligns the strong teaching learning assessment loop if we have a blueprint, because it clearly outlines the weightage, it aligns the exam question with the learning objective, and again, it distributes the evenly in the cognitive domain also. If we are assessing the cognitive domain also, then also we have the questions from the recall, from the understanding, and from the application, and it balances the question type, and it helps to plan the faculty in a systematic manner. And again, like I said, it is good for both the students and the teachers. So like Sheena is asking, if we share the blueprint with the students, when the question paper becomes too predictable to them? No, Sheena, it will not be. And even if it is predictable, see, what is our intent? Our intent is that they should know what is our intent of this whole teaching learning process, that at the end of probably this professional year, they should be able to have these many cognitive skills, these many psychomotor, and these many affective. So even if they know what will be asked, they will read that. There's no problem in that. Why we want to make it so shady and not to be transparent? Like if that's the same question people ask in case of a question bank also. Nowadays we say that you can share the question bank also to the students, but the rule is it should have like very hugely the ratio, if you say 100 times. Okay. Number of the student multiplied by 12. So like Dr. Shamshad is saying, like because recently we took this session in the faculty who of the AIMS Patna faculty also, and they also raised this question, like should we share this to the student, should we share the question bank to the student? We can share the question bank to the students also, depending if we have the question bank which has got the 1000 times question of the number of students. Let's say if AIMS Patna has got 100 students, and if I've got 1 lakh questions, means 100 multiplied by 1000, I can share the question bank also to them. There's no problem. Because ultimately, it is their caliber also if they can go through those 1 lakh questions and read them. and understand them. And that's our purpose. There's no problem in that. So even if we share the blueprint, and in blueprint, what if you share it at the topic level, they will understand. Like if I say that essential medicine is not that important, international health has got only 2 marks, then they will read that less and they will focus more on the topic, let's say epidemiology or communicable diseases, where there are more questions. So ultimately, if you are sharing blueprint, you are not making it very, I mean, predictable. Rather, you are helping both the teacher and the student to ensure a validity and a reliability. And that's essential, because our ultimate aim is like they should know what is important for them at the end, because we cannot teach everything which is important, and we cannot assess everything what we teach. So everything we cannot assess, but that's why we have asked from all of you, like we divide the topic into the must know, should know, and nice to know. And generally we'll see how we should have blueprint of all the topics. So they should understand that what are the topics which are must know, and they should have a clear cut like a guideline of that. There is no problem in sharing, and by this it is our fear, actually it is our fear that we are making it predictable. If you see, it will make the process more transparent, and it will ease both the student and the teacher, because then the subject of the element of subjectivity will not be there in the assessment, and that is, in a way, it is good also. Okay, so if you read any classical this medical education book also, they've also done a lot of work, especially in the Western this thing, on this blueprint, and they clearly says that yes, it should be shared with the students, and there's no loss of like predictive. I mean, you are it's our fear basically, which we are thinking, but yield is always good, and it encourages a positive environment. I hope I'm making myself clear to you. Okay, Sheena. Thank you. So there are some basic concepts in the medical assessment. Like I used few terms regarding the cognitive, the Bloom taxonomy. So the Bloom taxonomy and assessment, it classifies all the behavior under three domain. So this is domain of learning given by Bloom in 1956, and which got revised by the Anderson and Krathwohl in 2001. And they say that there's one domain which is the cognitive domain, and this cognitive domain is related to the knowledge and intellectual skills. There's a second domain which is the affective domain, and this domain is like basically the communication, like what is the attitude, what values we have, or the student when the students interact with the patients, with what attitude, with what communication strategy, with what feeling they interact with the patients, they see them. That's the affective domain, like demonstrating empathy while breaking bad news. So we have got these days lot of OSCE stations of breaking bad news, how we can demonstrate empathy. And again, there's a third domain, which is the psychomotor domain. So psychomotor domain is purely related to the skill, like performing a venipuncture or a surgical procedure. In community medicine also, like doing the anthropometric examination or doing any clinical examination, measuring the mid upper arm circumference. All these are the psychomotor, comes under the psychomotor domain. So this is the Bloom's taxonomy. We teach using this Bloom taxonomy, and we should assess also using this. So that's what I was telling regarding the teaching learning process and the assessment, that there should be alignment between these two. So once you frame this teaching learning process, the specific learning objective, and when you make the assessment in alignment with those specific learning objective, then this whole process of teaching, learning, and assessment becomes aligned to the each other. Then a student who is only good at cramming things will not perform very good in the exam, because to perform good in the exam, he should have the affective skill also, and he should have the psychomotor skill also. Now, another concept which we use in the medical education and assessment, that is the Miller pyramid. And all of you know about the competency-based medical curriculum, CBME curriculum. So that also have used this Miller pyramid, and this divides this whole teaching, learning, and assessment into four components. The first is your cognition, which says about knows. So what student knows, and that we assess using the MCQ, LAQ, and SAQ. Then comes your knows how, means the higher level, like you can say the analysis and interpretation. This generally we assess using the extended matching questions, and like Ria was saying, the problem based questions, scenario based questions. That's the knows how when you assess the higher level of cognitive domain, which is the application and interpretation. Then comes your shows how. Shows how you just assess these shows how in a simulated environment by giving the simulated patients or by having a OSCE or OSPE stations. That's the shows how. And next comes your does. When they are actually doing this, then also you have this. And these days we are focusing a lot of this workplace based assessment. And this workplace based assessment, like 360-degree assessment, and then there is a mini KEX examination, mini KEX assessment. All these is like assessment of does activity, which are very much frequently these days we are practicing in the clinical setup. But again, this is not very much relevant to us in the community medicine, but again, we can think of this in the future. But right now, since we are struggling with the basic summative assessment, means the blueprinting of summative and formative, once we have set this, then we can go to the higher level of assessment, which is the 360-degree assessment and the workplace-based assessment. So basically, this Miller pyramid, this describes this assessment and the teaching learning process into these four levels. That is the knows how, shows how, and does. And again, like I was saying regarding the cognitive, if only in case of a cognitive also, if you want to assess, you should assess the higher level of cognitive domain also. So these domains are like the base one is the remember. So most of us like focus mostly on remember. Then comes your understand, and then comes your apply, then comes your analyze, and then comes your evaluate and create. So these are the six levels of the cognitive domain. And this again, you people have also responded to this, like whenever we assess what proportion of the questions should be from the knowledge part, what should be from the understanding, and all these three, we have clubbed it together as application. So we have one here as a remember, the second is understand, and the third we have clubbed it. Why? Because it is very difficult to have those many grids. So all these have been clubbed as a application based questions. So now coming to the this assessment and evidence, if you see this work was done by the this Miss Lavi RJ, and they said that whenever we why do we basically do the assessment? So because when we have learning outcome or competency, the instructor or the teacher, he wants to say, he wants to claim that this student can do this X activity. But if he is making such claim, he has to gather the data. So that data gathering process is basically the assessment task. So he gives the assessment task to the student, and this test provides the opportunity to for the student to perform, and then the teacher collects this evidence, and this evidence is basically the answer sheets of the student, the checklist of the OSCE or the clinical reasoning steps, and then based on these he does the validation. And that validation is like whether the student has attained a particular competency or not. Whether he has attained yes or he has not attained no. So basically, this whole assessment is creating evidence and validating that evidence about the student learning outcome. So I have introduced two terms here, learning outcome and competency. So what are these two outcomes? So if you see, whenever we form the blueprint, these two terms, learning outcome and competencies, they are the foundation of a test blueprint. So what are these learning outcomes? So basically, learning outcome are the broad goal. For example, like if I say demonstrate the understanding of the cardiovascular system, this is my learning outcome. This is a very broad in nature. But if I have to specify the specific competency or the instructional objective, what I will say? I will say that explain the steps of cardiac cycle. This is a more specific. So learning outcome is broad, and when you form the instructional objective, it is like small. So this behavioral objective is more or less like a specific learning objective. And we hope that you all know about this specific learning objective. What is this specific learning objective? These are the learning objective. Uh, we are not going to emphasize much on that because it's a separate session, the how to form a specific learning objective and all. But specific learning objectives are the objectives which we set in the beginning before we start a teaching learning process. So test blueprint is basically, it's like a roadmap. So basically you draft a learning outcome, you make your objectives, and generally if you are guided by some university, like let's say these days NMC, if most of us are guided by NMC, so you can take, because they have drafted all the competency based curriculum. So we have all those competency and the specific learning objectives under those competency. We have got the assessment methods also, and then we have to decide the weightage of that. And then after that, we have to ensure the validity. So a test blueprint is basically, it's like a roadmap. We start from the learning outcome, and at the last we validate after gaining the data and taking the sheets of the student, we validate whether the student is able to perform a particular objective, or he was able to perform up to the mark in the exam or not. So am I making sense to all of you up till this point? Should we take, I think, we plan to take a break after 40 minutes? Huh? Okay, 2:13. Should we continue? I think we can take a break of 5 minutes, and then again we'll come with this process of blueprinting. Anupriya is asking, is there any gross difference in learning outcome and objective? Yes, Anupriya, actually learning outcomes are very broad. Like, just a sec. Like I've shown, just talked about the cardiovascular system. The learning outcome is like the student should understand and apply the principles of cardiovascular system. That will be very broad. But the specific learning objective are very specific. Like I say that describe the process of assessing interpreting the ECG. So interpretation of a normal ECG will be a specific learning objective under that learning outcome. So that's the difference between the learning outcome. Means the learning outcome, like you have already written gross word. The learning outcome are very broad and the objectives are very specific. The second is like Uma is writing, is there a blueprint for practical? Yes, practical. There should be a blueprint for practical exams as well. You should have the competency based on that show how because that does is not there generally. So show how you can have, and that's how the importance of the OSCE and OSPE stations. So these OSCE stations you can plan for the practical exams. This was for one. And again, you can make assessment also based on some, like we take clinico-psychosocial case review. There it is very unstructured. So you can have like structured assessment of that clinical social psychosocial case review also. Okay, so Anupriya said, okay, then we may continue from this. So now comes the process of blueprint. So this process of blueprint is basically, you will see that this is a 4-step process. So the first step is you have to identify the major knowledge and skill domain. And generally, if you go by the competency-based medical education, they have drafted a set of competency and skill domain also. But again, if you want to have your own, you as a group of faculty also you can sit and decide, and you can club also many of the competency which is there in the competency-based medical education. This competency based, yes, that CBME guidelines are there. What logistics you require for that? So you require the content outline, you require the clinical skills, like the one girl was asking regarding the practical this thing. So you should have all the practical or clinical skills also which you want to test. Like for cardiology, that example, I have taken this from that article, which will share the reference. So for cardiology, like ECG interpretation, cardiac cycle physiology, the common conditions that can be there. Again, after you have identified the major knowledge and skill domain, the next is to have your specific learning objective or the assessment objective. So for that, you can delineate the specific learning objective. And we have also shared the 3 topics with all of you where you have filled the response. There you can see that there's a major topic, and under that major topic, there are few specific learning objectives. So you have to define those learning objectives, and then you have also to define the competency or skill domain, whether it belongs to the affective domain, it belongs to the psychomotor, or it belongs to the cognitive. For example, if my specific learning objective is like interpret chest X-ray for pneumonia, so this is again a specific skill or a psychomotor skill. So first step is to identify the content area, major knowledge and skill domain. Second step, you should have the specific learning objective or the learning assessment outcome. The third is you have to decide the assessment format. What do I mean by assessment format? Means you should have the, uh, uh, generally it is guided by the university question paper. Because generally in all the universities, whether it is a state university or it is a AIMS also, it has got a pattern, like how much MCQ. It is only in the theory. They don't give guideline for practical, but for summative theory they have that these many MCQ, these many SAQ, LAQ, that is there. But for practical, you can have, and again, you have to see whether what are the logistics, time, and resources. Because for planning these things, you need a lot of, because if you have to have 15 OSCE stations, you need a big room or a corridor like thing where you can plan these 10 to 15 OSCE stations. So you have to keep in mind, because for OSCE also you should have those many uh, uh, people who will be standing there or filling out the checklist. So those resources in terms of manpower, in terms of infrastructure, in terms of other resources also, you should see what all feasibility. So that is also there whenever you are having your blueprint. And then next is regarding the weightage. So we'll discuss more on this, how to specify the weightage. There are 2 terms, that is the I and F. I is the importance and F is the frequency. So we'll understand these 2 terms and how we will assign the weightage of each of these specific learning objectives. So before we start the blueprint development, so after attending workshop, if you plan to develop your own blueprint, what all or your team should have. So what all input we need for a blueprint? First is you should have your curriculum. because from curriculum only, you will identify the content area. And remember this line, we cannot assess everything whatever we teach. That means we teach many things, but we cannot assess everything. So remember this phrase in your mind. You should have your curriculum document. You should have list of chapters and topics, and it will be good if you make specific learning objective if needed. You should have this must know, should know, and nice to know categorization also. For example, we have also sent the activity sheet to all of you, and you people have filled out regarding each SLO, whether it is a must know, whether it is a should know, and whether it is a nice to know. So you should have this categorization also. And then you can have this SLO bank or topics per chapter. Then you constitute a team of 5 to 7 faculty members. So it depends if there are less in number or you should invite more people. You can have an inter institute also, like in the state also you can identify few more. It can be in intra institute or it can be inter institutes also. Like many other institutes can also be a team member. And then you have to identify this importance and frequency. This is a way we assign weight to the topic and the SLO. And this I stands for importance and F stands for the frequency of occurrence or frequency of these topics of occurrence and encounter. So this judgment format we decide, and then we define the cognitive domain definitions also. Like we have defined the cognitive domain under three. First is your knowledge, the second is your understanding, and third was your application. And we clubbed all the higher into one, that was the application. So you can define these cognitive domain definitions also. And then you should have assessment structure. What do I mean by this assessment structure? That means that you should have how many MCQ, how many LAQ, how many SAQ. That is for the final university exam and the pre-professional exam. So that's the assessment structure. Now, starting with the process of making blueprint. So, like I said, that these logistics in the form of the curriculum document, the topic, the specific learning objectives, then the must know, nice know, and should know, and then the specific domain, whether it is knowledge, understanding, and application, that should be there. And then you start forming a team. So you form a faculty group, and 5 to 7 is recommended. You can start with that, and then you finalize the list of topic. So to finalize the list of topic or SLO, like this, we have shared with you people. Like let's say chapter is the diarrheal disease. So what is the difference between chapter, topic, and SLO? And with this example, we want to clarify that let's say chapter is of diarrheal disease. There are 4 topics in this diarrheal disease: classification of dehydration, ORS therapy, zinc and adjunct therapy, and rotavirus and prevention. And the specific learning objectives would be, like in first case, the classification of dehydration as per IMNCI guideline. The next is your identify clinical signs of severe or some dehydration. Then you differentiate between the isotonic, hypo and hypernatremic dehydration. Under the ORS therapy, we have got 2 SLO. Describe the composition and preparation of low osmolarity ORS. Administer ORS according to plan. And under this zinc and adjunct therapy, this is 1 SLO. So this slide explains the difference between the chapter, the topic, and the specific learning objective. So then you, after you have finalized the list of topic or SLO, then the faculty, you send it to the faculty, and then faculty will independently rate this impact and frequency for each of the topic. Then you have to multiply this impact and frequency for each topic or the specific learning objective. Then you add all this impact and frequency to get a chapter level I into F. That is the impact and frequency at the chapter level. And now you know what is a specific learning objective, what is a topic, and what is a chapter. And then you calculate the mean of this importance and frequency for each topic or SLO. Then you calculate the weightage. We'll do it. All these activity, we'll do it one by one. I'm just explaining it right now. And then we multiply it by the total exam marks to get the final marks for the each chapter. So this again, I'm emphasizing, this is your chapter level, this is your topic, and this is your SLO. Then comes your assigning weightage. So we have seen like each faculty should independently assign weight to the topic. So what is the criteria for this assignment? So you assign weightage according to the content. You assign weightage to the domain of learning also. Like we have seen, the domain of learning means like knowledge, understanding, and application. And also based on the method of assessment. Whether you are taking a MCQ, you are doing a SAQ, or you are doing a LAQ. And then you decide the total weightage and number of items to be included in the assessment. So there are guidelines for these assigning weightage. And then again, there are different guidelines for the clinical subjects and for the basic science subject. And like I said, all that is expected cannot be taught, and all that is taught cannot be assessed. So you should remember this. Then let's see what are those guidelines for calculating the impact and frequency. So for clinical subjects, if you see the clinical subjects, how do we define this impact? So this impact is defined as, if it is a high impact, we call it as a high impact when it is a life-threatening condition, and we give it a score of 3. If it is not that much life-threatening, we call it as a moderate impact. And if it is rarely important, low impact, means low impact on the person, then it is a, a less important or rarely important, we give it a score of 1. Again, regarding the frequency, if it is a very frequently seen, we give a score of 3. If it is somewhat frequent, we give it a score of 2. And if it is rarely encountered, we give a score of 1. For example, a condition which is a very common and a life-threatening condition, like let's say tuberculosis. The complications of tuberculosis can be life-threatening also, and it is very common also. So it will get a I of 3 and F of 3. So the total weightage will be 9. This is how we calculate the weightage, which is the product of I into F. Then how do we decide for the preclinical subjects? So for preclinical subjects, we have this I into F. So this I is the whether it is important for, whether it is not very important for clinical reasoning. We call it as a I as 1. If it is 2, we call it as a moderately supports the clinical understanding, and we give the score of 3 if it is foundation to the clinical diagnosis or treatment. In the frequency, we give a score of 1 when it is not often applied. We give a score of 2 when it is moderately applied. And we give a score of 3 when it is rarely needed to understand the pathology or management. Similarly, for paraclinical subject, we give a score of 1 to impact when there is a minor contribution to diagnosis or treatment. We give 2 to this situation when it is a moderate clinical relevance. And we give 3 when it is essential for understanding the pathology or therapy. Similarly, for frequency, if we give 1 when it is rarely used, we give 2 when it is intermittently used, and we give 3 when it is regularly applied. So this was for the paraclinical and the preclinical. So again, one question, can we use teaching hours of a topic as a proxy measure of frequency? What is your stake on this? Yes. So all of you are right. We can take the clinical like number of teaching hours that particular schedule has also as a measure of frequency. So it is reasonable to use teaching hour as a proxy measure of frequency when you have got the available structured timetable, and when you are starting to have a blueprint, when you are not very familiar regarding its like clinical this thing, whether the format of blueprinting, if you are not very familiar, you can use this also. So like here you can see for basic sciences and for the any this thing for the pre or paraclinical, if there is a large volume of content or topic that occupies a significant time in curriculum, we give a score of 3. If it is a moderate volume of content, we give a score of 2. And if it is a small volume of content, we give a score of 1. Like a basic science concept with a high clinical application but taught briefly will get a 3 into 1, that is the weightage will be 3. So again, one question to you. So should blueprint include only must-know topic? Yes, so all of you are right. So best is your blueprint should have 60 to 70% weightage should be of must-know, 20 to 30% of weightage should be of should-know, and rest 5 to 10% should be of nice-to-know. So it should be a mix. But again, 70%, approximately 70% of the weightage should be of the must-know topic. So now again, one question to all of you. Should this must know, nice to know, and should know classification be at the SLO level or at the topic level? You know by this time what is a chapter, what is a topic, and what is a SLO. SLO. So best would be at the SLO level. But for that, you should have SLO for all the chapters rather, topic and then chapter. Right. Yes, I think one person asked one question. Can you go up, Dr. Shamshad, in that chat? Yeah. So Sheena is asking, ma'am, who decides which criteria is to be used to assign the value of I into F? As you said, different criteria for clinical and pre-para. So decides means you want to say when we are having blueprint, or you want to have reference of this I into F, Sheena? When we have our blueprint, a team of faculty basically decides what I into F format which should use. Means if it is a clinical, like subject is different.
What is the meaning of I into F?
I into F means like, let's say, if I am from community medicine, and I will use the criteria of like which are important, a community public health topic. So in that I impact also, I will see, because public health is not of individual patient. So it will change from subject to subject. But the basic of I into F will be same. 1 will be given least and 3 is the highest priority in the impact and frequency both. But subject wise it will change. Why it will change? Because assigning importance and frequency to the topic, the context changes. If you move from a tumor, if a person who is practicing the, let's say, gastrointestinal surgeon or an oncosurgeon, for him, if he gives I into F to a breast cancer, and pathologist who is teaching this in a pathology class, the criteria will be different, means the meaning will be different. Again, the scoring of 3 to 1 will be same in all the specialty, but the only way of thinking, because a pathologist is not directly dealing with the patients, But again, he knows that if breast cancer, if it's being asked if there is a lot of cases of breast cancer, and it is important also, it is lethal also, then he will assign 3 and 3 into I into F for this breast cancer. Right? So who decides means basically the expert, the subject expert decides regarding this 3 to 1, and it's the convenience, and this changes from subject to subject, and a subject expert will decide, like a pathologist or a biochemist or a public health expert, a person who is making blueprint of MCH courses. Because here at AIMS, the people are now planning to have a blueprint for PG exam in the MCH course. There again, their importance and frequency will be again based entirely on the patient setup. So that's the difference between a clinical subject, a preclinical, and a paraclinical.
Excuse me, ma'am.
Yes, Rajat?
Ma'am, I just want to add one point here. In our institute in Manipal Academy, ma'am, they're also using this latest GBD data, ma'am. Based on the prevalence of the different diseases, they are giving a weightage. Impact factor 3 to 1. Also, they're taking on the number of prevalent cases the previous year. So every year they're changing the blueprint.
Okay, that's again a very, I mean, it's one step high. I can say like it's Manipal is like more progressive. Probably it should be, because ideally we just write that the cases are more prevalent, or in public health we say that more number of communities being affected. So definitely this global burden of disease study that will show the actual burden on the community, and based on that, if we assign the importance of the like score to those situation, that's really a wonderful idea, Rajat, and I really congratulate to your institute. I think we can also think of this here at our institute, probably because we drafted blueprint earlier, but we did not do it at the level of SLO. So now we are planning to have it at the level of SLO. So thank you, Rajat. Haripriya is asking, could you please show the slide of process of blueprinting? So process means
The process of demonstration.
like slide. She's saying slide. Means I have already shown it, Haripriya.
Yes, ma'am. Like after the multiplication factor step, you were showing different steps. One slide was there where we were showing the
That don't worry.
huh,
You have to do it. All this you
this one,
say.
this
This
one,
is
huh,
very
ma'am.
theoretical. Once
Mm.
you do it now, then I'll again come to this.
Okay, ma'am.
This is very theoretical. You will do each of these steps. So then after you have done it now, then it will become easy.
Okay, ma'am.
Okay, sorry. So now I was at this level. So should the all of you have answered correctly that it should be at the SLO level, and because a single topic, it can have a multiple SLO of different nature of importance. For example, in case of a diarrhea, also we'll show you one SLO. If a single topic is the diarrheal disease, let's say this thing. Topic is diarrheal disease, and SLO is like explain the classification of dehydration. The second one is like prescribe and prepare and prescribe low osmolarity ORS and zinc. The next is your explain rotavirus vaccine and introduction and national coverage, and then your describe the pathophysiology of secretory diarrhea. So if you see in one topic, there are many SLO, and not all SLO is a must know. If you see the first two, it is must know, and then next, third is a should know, and your last one is a nice to know. So one topic have different SLOs, and those SLO, I mean, it can have a varying number of SLO, and each SLO is having individual importance in terms of must know, should know, and nice to know. That's why the collection of this nice to know, must know, and should know should be collected at the level of SLO. Again, this question, should we take this INF that is the I stands for importance and F stands for frequency, at the level of SLO or at the level of topic. For example, if this is the chapter, the classification of dehydration, this is the chapter diarrheal disease. This is the classification of dehydration, ORS and zinc and rotavirus. These are the topics and these are the SLO. So like there are varying answers at both. Sushri is saying at both. Priyanka SLO, Rajat is topic. So again, it depends. What happens if you take at SLO level, you can club these and decide the weightage of at the topic level. And when you club the topic, you can decide the weightage at the diarrheal disease. So we'll show you that if you collect it at SLO level, you can apply this blueprint even in your formative assessment. Because in formative assessment, what happens? Many times in the terminal examination, you don't cover the whole syllabus. It's only few chapters. So if you take at the SLO level, then it becomes very easy to set the question. Even exact SLO, you can put it in the form of a short answer question. But again, even if you are doing it at topic level, see, you take the response at SLO level and then club it at topic level. At topic level, it gives a little flexibility to the examiner who is setting the paper. So probably for your internal use, you can use specific SLO, but when you send that blueprint to an external person, external examiner for setting the question paper, you can send it at the level of topic. Am I making myself clear to you? What I am saying that if you collect it at SLO, you can have the I into F at every level, at topic also and at chapter also. Because this SLO, merging the SLO will make the topic and merging the topic will make the chapter. Okay. So if you collect it at SLO, then you have the I into F at each three level, at SLO level, at topic level and at chapter level. But if you collect at topic level, then probably you will not have a specific weightage of this SLO. So it is up to you. You have this flexibility. You can decide on that. I think we have covered this. Why do we need weightage? So we need weightage because, think of a blueprint like a meal. So whenever we are going to have a meal, we have few content which are must eat. Like predominantly as an Indian, we eat cereal more as compared to the vegetables. If you don't count the reverse plate method, which we usually recommend for diabetic people, or for people for obesity to lose weight, generally all of us eat cereal in a larger proportion as compared to the vegetables and the pulses and maybe the dessert and the salads. So these are must eat, the roti and rice which you can see here. If you see the gulab jamun, this should eat means yes. And then salad, many people generally they take salad very less. It is nice to eat, but they take less. So a thing which is like in this case, if it is must eat, we take it in more amount. If it is like nice to eat, we take it as a low amount. And if it is should, then we take it as a moderate amount. So similar concept you can apply to the blueprint. If it is a must know, it should be more in number in the assessment. If it is should know, it should be moderate. And if it is nice to know, it should be less. So why do we need weightage in assessment? Because all topics are not equal. Some are critical for safe clinical practice, and it ensures that the important content are there in the assessment. Now, what are the methods to determine the weightage? So generally, there's one method which is known as the Delphi method. So this Delphi method is the group consensus through multiple rounds. In this case, all the 5 to 7 faculty, they sit together and they decide at each SLO level what should be the importance and frequency. In that case, you will not have many I into F. As you will see today exercise, you will have only one I and only one F. Because it is done through consensus. Means, let's say for tuberculosis, if I have one specific learning objective of like doing a AFB stain and putting it under the microscope. And if I say that yes, it is very important, I will say it as a 3. And it is frequency of occurring this situation is also very common. So I will assign 3. But this 3 and 3, it is given by a consensus among all the 5 to 7 faculty members, which we call it as a Delphi method. The next is a modified Enghoff method, which is based on probability of success. I'm not telling this in detail, just you remember it by name that this is one method which is a very mathematical method. This is not very commonly done because the calculation is based on the probability. Means probability of success means if one item is given, what is the probability that student will answer that item or not? And the third is your expert judgment. Generally, we use this expert judgment impact into frequency, and we will use this third example in our workshop. So what is this I into F scoring? This I is again how critical is the learning objective, and frequency is how often that is applied in the real world practice. So this if you see this, the range of this I will be from 1 to 3 and the range of this S will be from 1 to 3. So you will get SLO or this weightage ranging from 1 to 9 because maximum will be 9 and lowest will be 1. For example, assume there are 3 faculty and we have rated a specific learning objective or topic like this. Faculty 1 has given it as a I of 3 and F of 3. Faculty 2 has given it I of 2 and F as 3. And faculty 3 has given this as a importance of 1, this I as 1 and F as 1. And you have calculated I into F. So you have got I into F, maximum is 9 and lowest is 1. So there are 3 approach for calculation of weightage, which I into F you should take. So how you will take it? So the first option is you take there are different ways. So you can take the mean of I. So if you see this, mean of I and mean of F. And this is not through consensus, remember. If you are doing it through consensus, then you will only have one I and one F per SLO. But since you are collecting, you have given the sheet to the individual faculty and they have given the response separately. So that's why you will have data like this. So the I into F will be, this mean of I will be your 2, the mean of F will be your 2.33, and then this mean final score will be 4.66. So this is one way of doing it. The second way is what you can do. You can multiply this I into F for weightage and then you take the median of it. So median will be 6. So you take the median. And then the third approach can be you take the mean of this I into F. So mean of this I into F means 9 plus 6 plus 1. So its mean will be your 5.3. So generally we use this approach when we multiply this I into F and we take a mean value of it. Because why we take this? Because it preserves the actual weight. If you take the mean of this and mean of F, then you are disturbing the actual weight which the faculty has given. So by this method, it preserves the actual weight given by the faculty and it is easy also to calculate. That's why what we will do for today's exercise, we will take the mean of this I into F. So we recommend this option 3. So am I making my Self-clear. Okay, second approach. So Sushri's second approach was median. We don't take that. I mean, you can take that. This is one way. Median means I into F. You know, median, we arrange it in ascending or descending order, and you take the value of the middle uh, place, 50th percentile. So this is your median. So this is the second approach. Is it okay, Sushri? Saurabh? Okay. And then third is your mean of I into F. So we recommend the mean of this I into F in calculating the weightage. We will do this activity. But before we start that activity, there are few challenges with this blueprinting. This thing. So what are these challenges? Because it's a teamwork. So it requires faculty training. So all faculty needs to be trained. And this blueprinting, like Rajat was saying, it needs regular updation because curriculum also gets changed. And again, like disease scenario also gets changed with more treatment modality coming day by day. And like he was saying, they are using the global burden of disease, that's also gets changed. So generally it is recommended that you should change your blueprint after every 3 years. Not change means re-evaluate it. It will not change entirely, but there can be slight change in your blueprint. So yes, it needs a regular updating with curriculum changes. And again, there should be, because there should be a balance of this formative and summative assessment. So that also, because it takes time, the main thing is it takes time, the initial. Once you have it, then it will become very easy for all of you. But just this initiation of having a blueprint takes time. So this is one of the challenge. So best practice is start small. What do I mean by start small? You can start having a blueprint of only one topic first. When you gain confidence that you can draft a blueprint of one topic or one module for any semester exam for two topics. If two topics are coming in a semester exam, you can have a blueprint of that. And then scale it to a larger level when it will have more chapters, and then you can have a blueprint of, let's say, like paper 1 and paper 2 and so on. So always good that it is always appreciated that you start small. But again, because the main hitch is in starting. If you think of making a blueprint for whole of your summative assessment, it might take time and more energy, and then you will not feel like starting it. But this one module can be done even with 2 to 3 faculty. It's just an exercise so that you can feel confident. So you should start small. The next is, again, whenever you start, you just update all the faculty members regarding these principles, regarding this format of INF, and then you give the response, collect the response. And like I said, it needs a periodic review and modifications, and it should be shared with the students for transparency. So there are advantages of blueprint, like I said, regarding the validity and reliability of assessment. So if there are topics which are not of that importance, and if if there are important topic and we are not asking them, this phenomena we call it as a construct underrepresentation. Means there is a too little weightage for an important topic. And if there is a topic which is not important and that's been asked frequently, that's known as the construct irrelevance. And that is known as a bias or maybe the hot topics. So the blueprints take care of both these two threats. So it reduces the validity threat. For example, like if learning outcome is demonstrate ability to perform a cardiovascular examination, then I cannot form a MCQ. It should be a OSCE. So blueprint helps in mapping the learning outcome. In the beginning, we have seen this, like it matches the learning outcome, specific learning objective of teaching to the assessment. Next comes your reliability. So what is the reliability of assessment method? So basically the reliability means like if there are two students, and so I can say, I can delineate like who is a good student and who is a bad student. And but if the two students are of equal caliber, then my assessment should show that both the students are equal. So how we can do that? Ensure this reliability. So the first is your nature of method. Like for MCQ, objective format is highly reliable. If it has got same key, then there won't be any subjectivity in assessing the MCQ. Whereas the essays and long case, they are very subjective. So they have got lower reliability. The second is your number of items. If the number of items are more, reliability increases. For example, 100 MCQs are more reliable than the 40 MCQs or the 20 MCQs. Similarly, having OSCE stations, 10 to 15 OSCE stations are more reliable, highly reliable as compared to 2 to 3 OSCE stations. And again, if you standardize the checklist, like one checklist which has been standardized and being used by all the assessor, again, it helps in getting the reliability. So how this blueprint achieves reliability? So if, for example, if in the summative exam, if the question paper is without blueprint and there are 8 long questions from the general pathology and only one short note from hematology. So what it will show that if there are two students, both have read, one has read this general pathology very nicely and the other has read the hematology, but the marks which they will get, they will be very different. So that's how the reliability, you have not ensured the reliability. The third use of blueprint or the utility of blueprint is the feedback. For example, if the communication skills under the affective domain is one of the learning outcome, and if I am not assessing the communication skills, because you say that we many times that ATCOM is there in all the institutes, but not everywhere. We are not assessing communication everywhere. So if that is there, then this is an exam design issue. That means we are not aligning our exams or the assessment with the learning outcome or teaching. But if you have a OSCE station and if the student is performing bad in that OSCE station, then you have to review the teaching learning process, means how we have taught that. So this blueprint also helps in giving the feedback, reflect upon us, like whether it is a teaching learning gap or whether it is a exam design issue which has led to the poor performance of the student. Now, how many SLO or items you should include in your blueprint? So generally it is said that to have a reliability or the Cronbach alpha of 0.8, 50 to 60 items are enough, but maximum after 100 items, there is no additional benefit. So you should aim for maximum of 100 SLO or competency. And again, like I said in the beginning, you should see the feasibility and the infrastructure and the resources available in your workplace or institute. That should be taken care of whenever you are having a blueprint. So there are the few examples of blueprint. This is one blueprint in designing and validation of competency-based curriculum for theory assessment in community medicine. This is by the Medha Mathur, and you can see they have given the competency wise, like 1.1, all the I into F for all. And then they have calculated marks by taking out like this, rounding them off about all the chapter. This is again one article which got published, I think by Supriya, and they have prepared the blueprint for formative theory assessment. So the first one was for the summative, and this is for the formative, where they have, I think these were the chapters which they have asked. So the concept of health and all these. And this was this blueprint, we have done this designing a summative assessment blueprint community medicine, an expert consensus approach at All India Institute of Medical Sciences. So this we drafted involving, I think, all the 10 aims across all over India. And we started with 55 faculties. So there was a huge number. But then at the last, I think we 10 to 15 were the final one, because there were many dropout. And we proposed this blueprint because we proposed this grid of all the format of like MCQ, SAQ, and LAQ. And I think about this chapter level and having an individual grid also. And I think Rajat was also a part of, no, Rajat was not the part. Okay, and then this was for the paper too. So this was regarding the theory. Now we'll go to the hands-on. So before we go to the hands-on, any question? Okay, if not, so Sheena is saying, should we include? Yes, Sheena, that's I said na. You can have teaching hours. That's I said, like teaching hours can be a proxy indicator of frequency. If you devote a topic, a significant number of hours, you can give a weightage of 3, like F of 3, frequency of 3. That I think I covered it in the mid of the session. So how to validate the developed blueprint? Okay, we'll come to this, Dr. Uma, regarding the validation. Again, it will be through the experts only after you have drafted that. So some basics of Excel function. So this we will use this Excel. So this Excel is a spreadsheet, and this is a software which is there under the Microsoft, whatever version you use. We have got Microsoft 365, Office 365, and this we basically organize, calculate, and analyze the data. So in any spreadsheet, you will see that it has got a row and a column. So this is a column and this is a row. And each cell, if you see, that is the intersection of a row and a column. For example, if you focus on this cell is of E column and second row. So this cell address is E2, means the column is E and the row is 2. That's the intersection of second row and E column. And each cell, it can store text, it can store numbers, it can have formulas, and it can have dates and times. Now, there are some basic rules of putting the formula, and we will be using that. So like if I have to add this 20 and 30, we should always start with this equal to sign whenever you have to put the formula. And then you have to select a particular cell. And same principle will be applied whether you are doing a multiplication, a division, addition, or subtraction. Now there is something known as the use of brackets in Excel. So if you use bracket, like in this case, you can see this is one example where I have added this D3, E3 and multiplied it with the F3. So if you don't put bracket, it will do this multiplication first. So the answer would be your 5 into 3, 15 plus 2, 70. But if you want this addition to be done before the multiplication, then you have to put a bracket. So that means it will first add this 3 plus 2 and then multiply it with 5. So answer will be, what will be the answer? Yes, all of you please write in the chat box. Yes, 25. Now we'll see the basics of this pivot table in the Excel. So this is the simple data set. So I have to show here or in their data set?
क्लिक कीजिएगा आ जाए
Okay. So this,
चल चल
I think we'll show it there. Yeah. Just one. देख लेते हैं.
क्लिक में दिया
We'll show this pivot table option there in the. एक मिनट देख लेते हैं. Blueprint में ही देख.
एक पीस
Okay.
यही भी होगा बहुत बड़ा आता है
So if you have to, like this is the Excel, and if I have to make a like result, so how this pivot table will be? So there is something known as insert. To put your cursor anywhere in the data, this is important because if you put outside the data, then it will not be activated. So put your cursor anywhere in any of these cells, go to insert, and then there's a pivot table. So click this option of from table. So I've clicked this option of from table, and here this takes the range automatically, table 2. If you see all these dashed line, can you see these dashed line? So it selects your table, wherever the data is. And then it will ask about the two option, whether you want your pivot table in a new Excel sheet or in an existing worksheet. So by default, this new Excel worksheet is clicked, and you have to opt for this option only, new Excel worksheet. And then you have to press OK. So if I press OK, another sheet will be opened. So you can see this was sheet 2, and just before that sheet, this sheet 1 has appeared, and this is the pivot table. So now, like let's say, what do I want? So I want total pass fail. So I have clicked that, whatever you click that will appear here. And let's say if I want to see this total as a value, so this values is a sum of total. So I can see out of total 250 female and 472. This is the marks basically. Actually, if we would have the question, it would be easier. But let's see.
इसमें कुछ भी पासवर्ड का परसेंटेज
हाँ, दिखा दे रहे हैं. चलो.
नीचे रीसेट होल्ड रख सब
एक second. If I have to remove that and result, you drag it to here. So you can see like two female have passed and 3 male have passed. So similarly, you can make a table like this. We will see this option more in case of a blueprint, because there we have to make like chapter wise, topic wise, etc. So this will help you in having a blueprint. This pivot table option will be needed. So now I will go to this demo sheet of Excel. So this was the activity. This was the activity which we have given. So the activity 1 was you had to give response at the level of SLO regarding the must know, nice to know, and should know. Then the activity 2 was you have to give the weightage, that means I into F, at each of these SLO. And the third activity was you had to give the percentage allocation of MCQ, SAQ, and LAQ. In MCQ also, what will be the level of cognitive split, like recall, understanding, and application? And similarly, they recall, understanding, and application in SAQ and LAQ also. So these three responses or activity we have received from all of you. And I think we received these participants' responses, and we have clubbed, I think we have taken the response of 7 to 8 people. There, I think, let's say what you have given the response, I will just show few responses. So this was okay, like activity 1. Activity 2 was also okay, like 3 and 2. But in activity 3, many people, what they have done, like if you see this MCQ was 30. So what they have done in the percentage allocation, they had to write like 33, 33 and 33. But they have given like 10, 10, 10. Means in this, you have to take the response in the form of a percentage allocation. That means the total of this should come 100. So we have converted this back. That's okay. But just for demonstration, we wanted to show that this is like, this is not 10, 10, 10. It should be like 33, 33 and 33. Am I making myself clear to all of you how you have to take the response? Okay. So now I will go to this. Let me close this. So this is the demo sheet. So we have, these are the category of MCQ, SAQ and LAQ. And we have taken the responses of 7 faculty. So this was the response of first faculty. That means he has said that 20% should be of MCQ, 60% should be of SAQ, and 20% should be of LAQ. Similarly, I have taken the response from faculty 2, faculty 3, faculty 4, 5, 6, and 7. Okay. Now I have to use the average of these responses because everyone has given the different response for MCQ, SAQ, and LAQ. So I have, because I cannot use anybody's single response. So that's why I'll use average of this. So how to calculate average? In Excel, what you will do, you will just do this equal to average. So if I write average, this average will appear here. Double click this and select this cell and press shift and select up till faculty 7. And you can also see the cell. So this is C12, this is C2 to 12. And then again you press enter. So this is the average. So I will take the average and then again, if you just double click this, this formula will be applied in this whole column. Even if there are, you can see here, there are blank cell in between. If I just click that and if I just drag this, it will calculate the average for all. But wherever there is nothing, you can delete this. So this I have deleted. I will repeat. This I have deleted. So this is how it has calculated the average. Not audible.
We are not able to hear you.
Okay, let me check audio setting. Am I audible now?
It's a
Yes.
Okay. Sorry. So I will demonstrate once again. Let me delete this. So what I was telling you, I will. Sheena, the weightage for MCQ, SAQ is decided by the university, right? Or is it decision of faculty? Yes, Sheena, generally it is decided by the university. In the summative, it is decided by the university, but for formative, you can decide. And many times, university also, there is some, means they have also arrived to this process through some consensus. So they, so if it is already decided, then you don't need to do this exercise. Like for us, it's already decided that these only one LAQ will be of 10 marks. There will be 35 marks SAQ and 30 marks MCQ, 15 marks MCQ. Because the total paper here at AIMS, the paper paper one, each paper is of 60 marks. So since it is already decided, we will not do this exercise. Generally it is, but again, I mean, this is one way you can take this activity for formative. Also you can have this, and you can take like for these like recall, understand and apply, you can take that. Because if already decided that these many percentage will be of MCQ, but that further breakage is not there, how many should be of recall, how many should be of understanding and application, then you can take that response if from the faculty. So now I'll calculate average equal to. So I said that whenever you have to apply any formula, you have to start with equal to. So I'll write equal to first. After equal to only, the Excel takes any formula. Am I making myself clear? So don't forget equal to. Otherwise, your formula will not be applied. And then select average. Because many times I also, if I'm in very excited mode, I always forget equal to and start applying the formula. So I have typed like AVE, then this average comes. Double click that. I'll once again do it. Put equal to, write average. Start writing average. Once you start like AVE only, average, you can see here average. Then double click this. Once you double click this bracket will appear. Once this bracket will appear, and it also guides you. Here you can see number 1, 2, 3. Once that bracket appears, then you select first cell. If you select, you can see it is now the first cell is selected. Then press shift, or you can increase this range. You can, now it has, now I'm like I did a wrong this thing because this has got missed. So again, I will select this F1, press shift, and then start selecting till F7, and then press enter. So this is the average in this first cell. And there's a beauty in Excel, like if you have applied formula in one cell, and if you drag that, and for dragging also, you should understand this sign, this plus sign. This plus sign. Let me see. I will delete this. I will delete this. Can you see this plus sign? There are 3 plus sign. This plus sign, can you see this sign? If I press this, na ye chala jayega. Ye nahi aayega, haan. So this sign is there, and then there's a bold plus, this one. Once this appear, then just double click that and it will be populated. If you drag it, by keeping your cursor, press the left this thing, a mouse, and then drag it down. And then delete wherever there is a blank. This division is written here because here no formula, there's no number. So you delete this, and now this will be your split, like recall in MCQ 23%, 48 and 29. Similarly here 24, 40 and 35. And then 20, 39 and 40. Okay. And you can round it. So for rounding, what you can do, either you can apply formula or you can just write this is 30. This I will take as 40. And this I will take as 30. Again, you can write here that this you take it as 50. This you take it as 30. And this you take it as 20. And here you can write here as a 25. And this as 40. This is okay. And this as 35. So you can do the rounding. There's formula also, but there's no need because this is only 3. So 20, 40 and 40. So you can round it off. No need to take those many like 23 and 29, 48. So this you can do this activity. This is your first activity. And this we have collected it from all of you, these responses. We have taken only 7 responses. We have shared this data sheet also with all of you. So this you have to do first.
10 minutes, 10 minutes.
So giving you a 10 minutes breakout room activity. देख लेना ज़्यादा बड़ा मत खोलना. 4 हाँ, yes. 4 breakout room and we are assigning 4 people. I think Rajat, Haripriya. I don't know whether Deepika is there or not.
Computer.
Hey. Manisha is also there. And Ria is also there.
Hang on. Just one.
So we are opening all the breakout room. And I think there is a mentor. We have distributed the mentor. I think Venkatesh is there, Ria is there, Rajat is there, Haripriya is there, Deepika is there. So you can all see the activity, and it's a 10 minutes active. 10 minutes. We have allotted 10 minutes to this activity. So please do this. We have shared the data sheet with you people.